Interesting paper published way back in 2014 in Human Reproduction, and this paper is titled Non-Visualized Pregnancy Losses Are Prognostically Important for Unexplained Recurrent Miscarriage. And this is a paper on behalf of H-Ray Special Interest Group on Early Pregnancy. And this is, I feel, it's quite relevant to us because we commonly see in the practice of infertility patients coming to us saying that, well, I had one clinical miscarriage, but then I had 2 times a urine pregnancy test coming positive and it did not progress. At the very next day I got period before I went to the doctor, or the ultrasound did not show anything. And we really don't know how much we should give importance to these kinds of unvisualized pregnancy losses, and this paper typically highlights onto that. So biochemical pregnancy losses and failed pregnancy of unknown location share a similar prognostic importance. That's what is being tested in this particular compared to even the clinical miscarriages which take place. Non-visualized pregnancy, they are broadly classified into non-visualized pregnancy losses. They could be either biochemical losses, that means they have just undergone a urine pregnancy test which is positive but the ultrasound is not done, or they could be an pregnancy at unknown location, a failed pregnancy at unknown location, wherein they did a biochemical test or maybe a beta HCG, went for an ultrasound and a pregnancy was not detected, and they were called PUL. But believe me, both these categories are not included in the ASRM definition or even H-Ray definition of repeated pregnancy losses. But nowadays they are quite often diagnosed because the urine pregnancy test is rampantly available, and sheer anxiety and curiosity of the couple that as soon as the date is postponed, in the very 1 or 2 days they will do a pregnancy test and come back to us. This particular study used the data of 10 years of Danish recurrent miscarriage clinic was used in particular data. So about 918 women of Danish recurrent miscarriage clinic from year 2000 to 2011 were studied. They were put into 3 categories. One is USG diagnosed pregnancy losses, and let's call them clinical pregnancy losses. The second was failed pregnancy at unknown location, that was an beta HCG positive and a sonography did not reveal anything. And the last is the biochemical loss of just a positive beta HCG or a urine pregnancy test, and USG was not done. There were total about 2,454 pregnancy losses, and out of them about 23% were biochemical, 16% were pregnancy of unknown location which have failed, and about 58% of clinical miscarriages were there in the data, which is as shown in the picture. And interestingly, the biochemical losses took place at 6.08 weeks. The peak was at that level, and with the pregnancy of unknown location, the peak was at about 6.51 weeks, while the clinical miscarriages, the peak was about 8.8 weeks. So the clinical miscarriages were a little later compared to the biochemical and the pregnancy at unknown location, which is commonly witnessed by all of us. What they found out was for women with more than 2 clinical miscarriages, which are unexplained, the risk ratio of live birth rate is 0.89, which is same as the risk ratios of live birth rate after a biochemical pregnancy loss and a pregnancy loss of pregnancy at unknown location loss or a failed PUL loss. So having a chance of a risk ratio of live birth rate or predicted that live birth rate will also be a little lesser is common to all 3, the clinical pregnancy, biochemical and PUL, and this particular thing is not noted by us and conveyed to our clients. What they found was the age. If the first pregnancy loss was at a higher age, the risk was a little more in the future pregnancies, and obviously this is the age related story and which will continue. Interestingly, the body mass index did not have an effect on the odds ratios at all. So this was independent of the body mass ratios. The fact that she just had a biochemical loss or a failed pregnancy at unknown location increased the chances of having lesser live birth rate later. They also looked at the treatment analysis. They gave various kinds of treatments. So looked into giving progesterone, HCG, etc. And they looked at the IVIG. And this is what I want to convey you, that when it came to giving tender loving care or some treatment, the odds ratios were almost the same. But with the IVIG group, about 98 women received the IVIG in addition to tender loving care, and they had a risk ratios of 1.227 with the confidence intervals on the positive side of the unity. So giving IVIG treatment in patients who have unexplained repeated pregnancy losses could be having some positive effect there. Non-visualized pregnancy losses, like clinical abortions, have a similar effect on live birth rate, and odds ratios remain the same. And with each non-visualized pregnancy loss, there is a decrease in risk ratio of having a live birth rate by about 10%, and that's very important. So I think whenever the couple complains to us about biochemical losses or failed pregnancy of unknown location, it's not our practice, guided by the HRA and ASRM guideline, to investigate them thoroughly, but at least prognostically, we should take into account that the odds ratios of live birth rate could be little lesser, and that should be conveyed to them so that they probably get investigated more and may receive some empirical treatments. And IVIG is something which is definitely coming up on the horizons, with even a meta-analysis publishing that IVIG in unexplained recurrent pregnancy losses could be making a difference. I'm sure to give one more presentation on that in as soon as possible on the papers on IVIG and unexplained recurrent pregnancy losses. Thank you.